you very much.
All right, thank you. Thank you all for being here, and we're going to get started with our panel. And I just want to introduce briefly the folks who have joined me up on stage. Immediately to my right is Douglas Reich. Reich, is that the right word? Reich, Douglas Reich. Doug is the medical director for the Department of Family Medicine at the Bronx Lebanon Hospital Center, a healthcare facility serving poor, underprivileged community in the South Bronx. He is a pioneer in building CHW programs with appropriate training, support, and supervision, and he has developed innovative approaches to financing CHWs in a more sustainable model. He served as the co-chair of the CHW Financing Work Group for us. Thank you, Doug. You've all met and know how wonderful Jacqueline is, so we're going to move on to, thank you, Jacqueline, for being wonderful. Yvonne Stinnett. Yvonne is the executive director of the Community League of the Heights. During her tenure, we got some more Heights people here. Did I hear some applause? During her tenure, she has participated in the development of over 1,000 units of low-income housing and is currently responsible for the management of 429 units of housing. In September of 2005, she opened the Community Health Academy of the Heights, a grade 6 through 12 school in partnership with NYC Board of Education, New York Presbyterian Hospital, and Columbia University Medical Center. Thank you, Yvonne. And to the far right is Elisa Estrella. Elisa is the Special Assistant to the Director of the Centers for Medicare and Medicaid Services' newly created Office of Minority Health. Her office coordinates minority health initiatives within CMS, develops CMS policies, regulations, plans, and programs to ensure that minority health interests are represented, and provides expertise on minority health disparities and interventions for addressing them. Thank you, Elisa. So let's just get started. I want to get everyone to kind of offer, the panelists to offer their initial thoughts and ideas, and I'll ask you just sort of one question to start, and then you can respond to that as you open up your ideas. And we'll start here with Doug first. We've heard a lot today about all the different ideas around community health workers. We've heard from state assemblymen, we've heard from policymakers. What is the most important thing for policymakers to know about this community and what it needs to go forward?
It's a loaded question, but thank you, Jamal. That's actually, it's as you can imagine, that truly is a loaded question. It's extremely broad in nature. What do the legislators need to know in order to provide appropriate funding to continue and reimburse the services that the CHWs are providing? They need to know, first and foremost, the role that the CHWs play with each and every patient. In preparing my notes prior to the presentation, I said that is the thing that the CHWs that I've seen working over 15 years have really been instrumental in doing. We heard Maria's story today. We've heard, and you've shared with one another regarding other stories from the CHWs. The impact that they make with each and every patient is critically important. Taking it to the next step, they also are fully integrated in our model into the medical team. They're involved in patient education, in shared medical visits, in resident and medical student education. Sergio mentioned research. They're involved in research efforts. So they really run the entire gamut. And all of these aspects are critically important when we're out selling and pitching this to the legislature. I mentioned to Sergio also when we took a break, next year what we ought to do is get everybody on a bus that's in this room and take us up to Albany, serve lunch on the bus, and politic the entire afternoon. They need to know who you are.
Jacqueline. Yeah, actually,
I'm just gonna feed off of that last comment that Doug just said right now. It's actually also getting to the health plan associations and getting to the hospital associations and the Community Health Center Association of New York State. There are these very well-organized associations that can really ally with community health workers, and it's really getting to them that really matters at this point. And the message, I can't articulate any better than Doug just did, is helping them to understand the role, the critical role that community health workers play as part of this larger team of healthcares. Community health workers, again, you've heard this over, you do this yourself, but it's the relationships that you build with the people that you work with that matters most. No one can do that better than the other people on that healthcare team. And helping people to understand that and get comfortable with that language is critical.
Yeah, you couldn't have said it better, but I just want to add that, there's a bigger picture in terms of the impact that the community health worker has on the broader community. You literally help to transform communities. If you change the individual's life, if you change the family's life, you're ultimately impacting an entire community. And that speaks volume in terms of healthcare, education, the economy. I think it's huge, and I think we need to broaden the conversation beyond just the impact on individuals and families, but what does it mean to change an entire community by the work that a healthcare worker does? It's awesome. That message needs to get out there as well.
What does it mean?
What does it mean?
Yeah.
When you teach people how to advocate for themselves, it doesn't just mean that they will change their health practice. It means that there are behavioral changes that become sustainable because they have not only adopted to better health care, but they now are looking their education, they're looking at changing their economic status, which actually means that you're changing how the community, the dynamics of what a community looks like. So it's huge.
Elisa, in your role at CMS, speaking with your colleagues, talking to other people who are in government structures, what is it that you think they need to hear or know about this community and how much it impacts people?
I think you would be happy to know that CMS, especially in the innovation department, the innovation is a new office also at CMS. It's got $10 billion to run programs on demonstrations, bundle system programs. Innovation Center is the one that's rolling out with the ACOs and the medical homes. There are all these different ways of transforming healthcare through innovative ways. And in February of this year, our former director was at the table when we were developing our strategic plan for eliminating racial and ethnic disparities. And he put on the table, and it's in the plan, and I don't know how many of you have seen it, but community health, the expanded use of community health workers, which has kind of forked into two areas, promotoras in HRSA, and also via the diabetes self-management training program for Medicare. So that's the first foot in the door, I think, in an agency like CMS that's a payer, because when you work with ADA and AADE, you can be reimbursed as part of the non-technical team for delivering the diabetes self-management training. So on that side, it's good news that we don't have to kind of prove the case anymore. But what we are working on is how to integrate it more into the new models that are rolling out. We don't really, and I don't mean to take on more minutes.
No, keep going.
The ACO models.
We came to learn from you.
Okay, the ACO model and the medical home models, when we're drafting those solicitations, we're not saying you have to use community health workers, but we are saying things like you have to have a proven demonstration working with communities. You have to have all this evidence that you've done this type of work with this type of vulnerable population or complex populations. So my advice in terms of what we need to know from you really is what you need to tell people about you is that you have the access to these people. You have the, for example, the language barrier problem for multicultural people. You can interface for them, you can interpret for them, you can navigate for them. You know, have that all kind of spelled out for your association or for your organization, and have your proven results of how you've worked in the community. And then take that and go to the National Medical Association and the National Hispanic Medical Associations and invite yourself to their table, you invite them to yours, and start having a conversation, because it's a partnership between the two of you that's really going to make a difference. You know, one of the bigger issues that we have is a shortage of providers that speak the language for the communities at risk. And the people that can really help with that, I believe, is you. You know, you're there in the community, you know. Even if it's English, you still know how to speak their language, you know. So, you know, I really see a lot of opportunities and ways to integrate, but it's going to take some more discussions with, not so much the people at CMS, but with the provider networks, you know, more partnering there to have them feel comfortable with you at the table, taking care of their patients.
Jacqueline.
Yeah, I wanted to respond to Elisa's comment right now, because I think we all had prepared written comments and we're ready to get started.
Yeah.
But I think this is a perfect opportunity to help define some of the terms for everyone in the room. You keep hearing these buzzwords like ACOs, medical homes, and health homes. I got to tell you, back at the foundation, it's taken us a couple of days to kind of say, okay, how are these things even different from one another? So this whole idea of an accountable care organization is that organizations are going to be held accountable for the health of an entire population, and they have to define that geographically. And who better than to get to the community than community health workers? So across health homes, patient-centered medical homes, and ACOs, the key words here are care integration, care coordination, and the third one is care management. And each of those things are part of the work that you already do. You help people navigate the system. You help people coordinate the multiple appointments that they have to keep up with. You help them manage their lives, basically, in order to manage their health conditions. And this whole idea of care integration is what Sergio was talking about in terms of a holistic view of health. It's not that you have to go to a behavioral health provider the next day after your primary care provider has told you should go do it, but that in one place, someone is explaining to you the connection between, yes, you should manage your depression in order to have your diabetes under control, but to be able to see the person as a whole, understanding their struggles with substance use, with depression, with diabetes. It's a whole person, and community health workers can understand that. The difference between a patient-centered medical home and a health home is that a health home actually encompasses more of the social services agencies, that it's a network of not just a primary care provider, but a collaboration across social service providers and behavioral health providers. And Doug can probably speak a lot more eloquently about what a patient-centered medical home is, but that's within a primary care setting, is making that the home for people to come in and get their health care services. I say all that because I feel like Elisa dropped in a lot of information, and I hope that you're taking a lot of notes, because the real challenge for everyone in this room now is to make the connection between what you do today and how people are describing the work for you today. Because you're already doing this work. You've already done the work already. The real issue is that there is new resources on the table. And I'm so glad that Elisa mentioned the $10 billion that CMS has now put out there for innovation. That's what matters. Those grants actually are worth going after. And many of you approached me during the break to ask, how can we get funding from the New York State Health Foundation? I'm more interested in helping you tap into the resources from CMS, because that's where we can take the work that's happening in New York and take it to the national scale. And as far as the New York State Health Foundation being involved, we'd love to see evaluations happen of these programs. We would love to help you get started on tracking your progress in getting that innovation up and running. There's no reason why, if you do go after a grant for CMS, the foundation can partner with you to help resource some of the things that are not covered by innovation grants. So I hope that most of you are taking notes, and you're also thinking about how you can work with each other in this room. What the New York State Health Foundation also is interested in is collaboration across the regions, across health institutions, across the healthcare sector, and by that I mean behavioral health services and the primary care system and the social service system, how the three of them can come together. But we're more interested, again, in bringing groups together and figuring out how this works across the board.
Doug, Jacqueline's referred to your eloquence, so
Yeah,
let's
let's not go
have an
that far.
opportunity to hear a little bit from you about that and
Well,
any opening remarks you want
Just
to make.
a quick comment, and that is, Lisa, how much money was that again? 10 billion.
It's
Okay,
not
10
only 1
billion.
year. It's
Okay,
not-
so, each one of you only needs, $1 million or $2 million, right? In order to make your program run for 3 or 4 years. But I think it's critically important to hear the potential partnership that can happen between you and the New York State Health Foundation. And so, especially when you're trying to glean, thank you, when you're trying to secure funding from outside organizations that clearly are bigger than who we are. So that's important. Let me talk for a moment about the patient-centered medical home, the role, and for a moment the health home, and the role of the community health worker. Many of you are may be already working within or part of a patient-centered medical home. The role, the scope of services that the community health worker can provide within a patient-centered medical home is everything that it talks about when you read the description of the patient-centered medical home. It's the integration of care. The CHW, again, I'm preaching to all of you that are converted, but those of you who are new to the scene, that the community health worker, they don't just focus on the medical. They certainly look at the medical, psychological, and social issues that are presented to them by the patient in the community and in the patient's home. So it doesn't just happen in the hospital or in a clinic or in a social service or an agency. It's actually happening in the community. And that's the power where you develop a closeness, a relationship with the people, with the patient, that then can empower the patient to actually take a role in their personal care, which is what we're lacking right now, our old model. And it was referred to in an earlier presentation that our old model doesn't work. It's broken. It has to be fixed. And truly, care management and the community health worker is what is going to fix our model. I want to speak for a moment also about the health home. Regarding the health home, so a lot of organizations, community-based organizations, have now signed up with larger organizations to participate in health homes. And if you have community health workers in your organization, you have the power. You actually are in a position to go to that larger organization now and say, hey, we got what you need. We can do care management. We can do care management with our community health workers in the community, in the patient's home, or in the clinic. So that means real dollars to you. So I think that's another very important take-home message from the conference this afternoon.
Mm-hmm.
Jacqueline, do you have any opening, or have you already given us your opening?
I'm just writing notes as my
Yeah.
mind is working really fast. The other question that, and I'm sorry, I feel like I'm taking your job away, Jamal, right now, but the question that becomes critical right now is who community health workers would be the most useful for, because resources are limited. I mentioned today that we spend $126 billion in healthcare. $10 billion may not crack in terms of making a real difference here, but the numbers that do matter is that 20% of the population that we know accounts for 80% of healthcare services. So just if you can just work with me really quickly, 20% of the population actually spend 80% of that $126 billion that I was talking about. Within that triangle, there's a 5% of the population that actually account for nearly 50% of that $126 billion. It's that 20% of the population where you all really make a difference. Mm-hmm. It's that population that CMS, Medicare, Medicaid, and the larger payers are really concerned about, because it's that population that is accounting for the use of these really expensive services, because we haven't gotten our act together as a nation, because we haven't focused on prevention and primary care, and people end up in the emergency room over and over again. And that's where your interventions make a difference. It's finding the people that have multiple chronic conditions, complicated lives in neighborhoods that don't necessarily have the best resources, connecting with those people, finding them, and bringing them into a setting that will actually help them prevent and manage their conditions. And that's what CMS is, that's what everybody is doesn't figure out. Not that they can't figure it out, it's just that collectively we've put together a system that doesn't work for that 20%. And we have to be able to be responsive to that.
Yvonne, do you want to give us any opening?
Yes, sometimes we make the simplest things so complicated.
Right.
What brought me to the table today was you heard the housing piece and all of that, but it's really the partnership that our organization, which is a not-for-profit organization, has been able to create with New York Presbyterian, working on the WINS asthma, now the WINS diabetes program. And I must say that it has awakened me to the power of the community healthcare worker in changing lives, and also, as I mentioned before, in changing communities. The cost, of emergency room visits, the cost of consistently going back to the doctor is so high in comparison to what could really happen if we had 100 CW, community healthcare workers, doing some of that preventive work. It is really awesome for me to have watched over the last 6 years the impact that the community healthcare worker, who's over there in the corner, Violetta, that has had on over 91 families. And I'm talking about the behavioral changes that have now almost eliminated the hospital and emergency room visits, have just about caused their attendance in school to be back to 100%. Those, someone mentioned before, I think it was you, Sergio, who talked about those soft things that we give, the commitment, the love, and all of that, that has totally turned around people's lives. Now, there isn't a price tag that you can really put on that. But what is awesome is also the fact that the community healthcare workers are connecting individuals to resources that exist right there in their communities that go untapped because people are not aware of them, not using them correctly, and therefore we are wasting millions of dollars on other resources that are going unused because no one is making the link and the connection between the families that need them and the resources that exist. And working with the WINS asthma program has taught our organization to be more useful, to be much more connecting in terms of our services, and taught us what types of services we need to now go to our elected officials and everyone else to advocate for. So there's a residual benefit that some of us don't recognize in terms of how it allows other resources in our community not only to be better utilized, but to be better advocated for. And I think we're changing as an organization how we now advocate for the other services in health education and promote the types of jobs like the community healthcare workers, which needs to be more a part of the medical system, but more a part of the community system and the infrastructure of communities.